All right. Good evening, everybody. Welcome to the first class of oral and maxillofacial surgery. One second. Okay. And I am with all of you. I am Dr. Himani Joshi. Till your friends join in for the class, just a quick introduction. I am a maxillofacial surgeon. I have done my BDS from Government Dental College and Hospital, Ahmedabad. After that, I have tried my hand in PG in the first attempt. I couldn't clear it during internship. My rank was 224 and seats were only 120. Then I took a drop, I prepared again, and thankfully I got into oral surgery at Maulana Azad Institute of Dental Sciences with an All India rank of 6. I completed my MDS from MAMC, and then I did my senior residency in oral surgery. I was fortunate to get senior residency at Lady Hardinge Medical College. I did SRship there for 1.5 years, and after that I was again fortunate to get SRship at AIIMS New Delhi and did the rest of my SRship at AIIMS. After SRship, I was again fortunate to get a pool officership, which is like a research associate post, again at AIIMS Delhi. I did 4 years of work at AIIMS Delhi, and after that I resigned. I wanted to work in a private sector. I wanted to teach, and for all of that, now I am with all of you teaching oral and maxillofacial surgery. All right. So everybody, whatever doubts, whatever questions, whatever communication you want to do, I am there with you. We are here live. You can see in the YouTube channel, I have put a hi there. Good evening, Pooja, Ranju, Angel, Pooja Kumari, Samriddhi, Rids, Urvashi. Good evening, everybody. I can see your live chats on the YouTube channel. Whatever communication you want to do, whatever you want to ask, wherever you want to pause, just let me know in the live chat and I will help you accordingly. All right. In this class, we also have two friends. This is one of the friends, he and his mandible. This is from the PG time. So I'll be happy to show you the surgeries live. I mean, not really live, but show you the steps here. And another friend of his, which is a little fractured. So I like to use the other realistic skull mandible. So I hope I'm able to explain everything to you. Whenever and wherever you are stuck, or whenever and wherever you need me to repeat anything, just put it there on the live chat. All right. But be alert, be sincere. One more request is do not make any notes. All right. All of you have oral surgery notes in the app. All of you have, some of you have it printed also. All right. Most of you have it printed. So if you have the notes, just open your notes and parallelly just see what is written and listen. What is more important is to listen. All right. Understanding is more important. If you keep writing, you will not be able to understand, because this is a slightly tricky topic which you haven't really seen in your BDS life. You might have read it, but you haven't really seen a lot of orthognathic surgeries. So it's best if you can listen properly. Notes are already there. Just read them later on. Another thing is, at the end of every topic, so if I'm doing orthognathic surgery now, at the end of this topic, we will take the latest previous year questions. All right. The questions from orthognathic surgery that have been asked in NEET or INI in the last few years. So that will be a quick revision of how to really connect theory with questions. All right. This will give you an idea of how to go back by learning theory, how to go back and solve MCQs. Okay. So this will be the flow. We will take a short break after 2 hours, that is at 7:30 p.m. You can have some coffee. If you have dinner, you can have dinner at that time. And during that break, we will have a special quiz in your Telegram group. All right. So all the live batch students who are watching this, be ready for that quiz also. And all the top rankers will be blessed. All right. So let's start without much wait. Let's start this beautiful subject called oral and maxillofacial surgery with the first topic, orthognathic surgery. All right. So what exactly does orthognathic mean? Okay. Orthos means aligned. All right. And gnathos, Gnathos, gnathos means jaw. So any surgery that is done to align the jaws properly is orthognathic surgery. All right. A person may have a very protruded mandible. He may not like it cosmetically. He may be having problems with it functionally. So it can be done for cosmetic indications. It can be done for functional indications. For any reason, if you are doing a surgery in the jaw bones, it is known as orthognathic surgery. Alright. Now, what are the indications? When do you really need to do an orthognathic surgery? A lot of times, people are born with problems. Congenital problems. A patient is born with Treacher-Collins syndrome. A child is born with Crouzon syndrome. So congenital syndromes, congenital facial features which need to be corrected, orthognathic surgery. Trauma cases. Sometimes the trauma causes a loss of a part of bone, an odd shaped bone, or any deformity which cannot be corrected or camouflaged. You can do orthognathic surgery. A lot of cases of TM joint ankylosis or other pathologies of TM joint like condylar hypoplasia or condylar hyperplasia, because we all know that condyle is the part which grows. If we talk about the mandible, condyle is one of the very important growth sites. So in a child, if there is any of these diseases like ankylosis or condylar hypoplasia, the joint is not growing properly. The bone is not growing properly. And that abnormal growth is going to cause facial deformity. If one is growing, other is not growing, asymmetric growth. If both are not growing, mandibular retrusion. If both are growing excessively, mandibular hyperplasia or mandibular protrusion. So any joint abnormalities that affect growth, you will have to do an orthognathic surgery to correct the cosmetic function. Patients of cleft palate. Cleft lip will not have much features or much effect on the skeleton, but cleft palate, when you have a cleft in a palate and you operate that cleft palate, the surgery causes a scar, and that scar causes improper growth of the maxillary bone. That causes maxillary hypoplasia. So very commonly you will see cleft palate patients who are operated for cleft palate with a hypoplastic maxilla. Alright. So all these indications and cosmetic indications which are beyond the scope of orthodontics. So whatever you can camouflage or whatever you can correct with orthodontics, you do it with orthodontics. You can do it with braces. All the dental asymmetries you can correct with braces or with aligners with orthodontic treatment, either by fixed orthodontics or by growth modification. But whatever is beyond that scope, orthognathic surgery. Alright, so now all of you know what is orthognathic surgery and what are the indications. Alright, so whether it is a concave profile, that can be due to maxillary protrusion or mandibular retrusion, or if it is a convex profile, either due to maxillary hypoplasia or mandibular excess. The ultimate aim of orthognathic surgery is to bring a straight facial profile. Alright, whether it is by a class 1 molar relationship or class 2 molar relationship or class 3 molar relationship, doesn't matter. Molar relationship should be a proper cusp fossa relationship. Does not always need to be a class 1 molar. Class 1 molar relationship is not a requirement of orthognathic surgery. An orthodontist is required to help in orthognathic surgery, but a class 1 molar, an angles class 1 molar relationship is not the aim. The aim is a balanced face, a straight facial profile, and a good function of all the oral structures. Alright, so I hope all of you are with me till here. Okay, now coming to why did we really need orthognathic surgery? Alright, so there were two people, Profit and Ackerman, and they developed this envelope of discrepancy. So how will you know which patient can be managed with orthodontics, which patient needs growth modification along with orthodontics, and which patient is beyond the scope of orthodontics and needs orthognathic surgery. So envelope of discrepancy tells you the scope of every treatment. The innermost envelope, which you can see here, is the scope of orthodontics. Considering this as the final position of maxilla, if you need a 4 mm retrusion, 2 mm intrusion, 2 mm advancement and 7 mm setback, it can be done by orthodontics alone. You don't need to operate that patient for orthognathic surgery. So this much is the scope of orthodontics in maxilla. Similarly, in the mandible, 5 mm, 4 mm, 3 mm, 2 mm. See, these all numbers are in millimeters. This is one MCQ asked in exam. They will give you this numbers and they will ask you what is that number unit, whether it is centimeter, millimeter and all of that, or inches. So it is in millimeters. The next, or the middle envelope, stands for orthodontics plus growth modification. You have all read it in orthodontic classes that there are a lot of myofunctional therapies that you do, like, the use of a chin cup or a headgear, or all the things that will modify growth till the pubertal growth spurt, till the child is growing. You can do that only till the child is growing, not beyond the growth age. So a slightly more envelope or a slightly wider envelope in the middle envelope. If you try and correct it in the growing phase, you can do better corrections. And whatever is beyond that, you need outermost envelope, which is the orthognathic surgery. In maxilla also and in mandible also. I'll be really happy if you guys give me a thumbs up and tell me if my speech is clear, if my speed is okay, and if you are understanding everything. I want to use Hindi, but I will not be able to use Hindi because of my South Indian students. They will have a problem. So just give me a thumbs up to let me know if you are understanding everything. I'm waiting for your thumbs ups. I know there is a slight lag. Okay. All right. Thank you for that answer. All right. So this is how the cases are selected for orthognathic surgery. If you watch closely, this child is a child of cleft lip and palate. You can see that scar on the lip, and of course he had a cleft of palate also. Because of that, there is a very, very severe maxillary hypoplasia. A maxillary hypoplasia which is very, very obvious here. Obviously there is a nose deformity also. There is hardly any upper lip show, and all this is because of that hypoplastic maxilla which is due to the cleft palate surgery. He is a candidate for orthognathic surgery. You will have to bring the maxilla out. This patient, another example, all these are cases from my PG times. Thank you to Mamsi for, allowing me an experience of this kind. He had burns in the neck. Alright, so he had severe burns in the neck, and because of those burns, there were post-burn contractures. Okay, PBCs, post-burn contractures. The contractures were so severe that they pulled the skin like this, and his jaw could hardly grow because of such a scarred skin. His mandible could not grow properly. Alright, and there was a flaring of mandible which you can see here. So his posterior occlusion is okay, but his anterior occlusion is absolutely disturbed. It's a severe class 3 with a very bad open bite and lip incompetence. So he will not be able to get corrected with orthodontics. He will need an orthognathic surgery. Another case, a different kind, no problems, no cleft, no scar, no trauma, just congenitally he is born as a severe class 3, a skeletal class 3. Okay, the orthodontist has tried to decompensate the dental problems, and this is how the occlusion is. Look where the mandible is in position with the maxilla. Normally there is a 1.5 mm overjet and overbite. But you can see the gross amount of reverse overjet that this patient has. The mandible is actually overlapping the maxilla. Okay, so this is beyond orthodontics. You will have to take the mandible back and correct the facial profile, correct the dental profile. This girl, another case, no problems, no syndromes, no nothing. She just doesn't like the smile. She said, I have excessive tooth show. Vertical maxillary excess. I don't like my smile, she said. So all she needs is, she needs her maxilla to go up. And maybe the chin to come out a little because the chin is a little less prominent. I would really like if her chin was like this. That is the scope of orthognathic surgery. Alright. Another case, syndromic trichocolins. Another case of hemifacial microsomia. You can see the ear tags. All these cases are indications for orthognathic surgery. And this is the magic of orthognathic surgery. Look at this girl. All we did was took her maxilla up, took her chin out, and this is how she looks post-operatively. That's how the changes can be brought about in the facial profile and in the dental skeletal profile with orthognathic surgery. Another case, I remember this boy's name also. Severe class 3 mandible. You can see the skeletal class 3 relationship here. Simple mandibular surgery is done. Mandible is taken back and you can see how absolutely straight profile is being created. Third case, which I just showed to all of you. Vertical maxillary excess. She didn't like her smile. We cut the maxilla, impacted it slightly, and this is how she looks post-operatively. So this is one surgery which gives the surgeon a God complex that, oh, I am just next to God and I can recreate the face. Although this is just a joke, no surgeon is really God. You can never absolutely change things. There are always cautions that you have to take. There are always risks in a surgery, and we will discuss all these risks and all these problems as we go ahead. But this is one surgery which gives immediate results, unlike orthodontics, and it gives a lot of patient satisfaction, a lot of surgeon satisfaction also. So this is the most thrilling surgery which I feel as a maxillofacial surgeon, and I really hope one day, if some of you want to become oral surgeons, I hope you get to operate such patients. All right. Now, coming back to NEAT, the sequence of steps for orthognathic surgery. Now, if I have to tell you the types of orthognathic surgeries, these surgeries are done during PG days. Yes, UG, you will not be able to see these surgeries. Her face is tilted to one side because it is immediately post-op. This is an immediate post-operative case. The swelling is still there. The surgical swelling is still there. I think this is 5th or 6th day post-operatively. There is still some surgical swelling. As it settles, there will be no asymmetry. All right, Aditi? Okay. Now, if I have to divide the types of orthognathic surgery, I will broadly divide it into conventional orthognathic surgery and surgery first approach. Okay, these are the two sequences, or these are the two approaches with which you can perform an orthognathic surgery. Now, first I will talk about the conventional surgery. How do we select a patient? How do we proceed for the conventional orthognathic surgery? The first step in conventional orthognathic surgery is pre-surgical orthodontics. Now, imagine a patient who has a severe class 3. Okay, imagine any of these patients. Okay, imagine, let's take this patient. If this patient has a severe skeletal class 3, do you think his teeth will be perfectly aligned? No, right? There will be some dental compensation. There will be some dental compensation which has happened over the years. So maxilla is correct, mandible is here. So all the teeth have a tendency to meet each other. So maxilla will try to procline, maxillary teeth will procline, mandibular teeth will retrocline. Okay. So if this is the normal maxillomandibular relationship, in this child, because the mandible is here and maxilla is here, his maxillary teeth will try to procline and his mandibular teeth will try to retrocline. just to meet with each other so that he's able to chew. Okay, that compensation is done by nature. The nature will try and compensate the dental arch or compensate the dentition on behalf of the skeleton. Okay, skeleton abnormal hai, but teeth will try to touch each other. There is always a cusp fossa relationship. The incisors will always try to meet each other. So instead of this relationship, the patient has this kind of relationship. Now, if I perform orthognathic surgery and take my mandible back, imagine where his dental status will go. It will be like this. If I do the orthognathic surgery directly, his maxillary teeth will be here, his mandibular teeth will be here. There will be no overlap, and ultimately you won't be able to eat. The patient will not be able to eat. So the first step before any orthognathic surgery is orthodontic decompensation or dental decompensation. What is the meaning of decompensation? Means the orthodontist will correct the alignment of upper teeth. The orthodontist will correct the alignment of lower teeth so that once you do the surgery, they become into normal relationship. Initially, the patient will look bad. Initially, his class 3 will worsen because the mandible teeth are back. Now the orthodontist is straightening it. But that is the first step. Before any orthognathic surgery, you have to correct the dental alignment. Also because a stable surgery needs a stable occlusion. If your occlusion is not stable, the outcome of your surgery will not be stable. Your surgery may relapse. So for a stable surgery, you need a stable occlusion. And how will you get a stable occlusion? By first correcting the dentition of the patient. So whatever crowding is there, whatever spacing is there, whatever rotations are there, whatever abnormal incisal relationship is there, you correct all of that with pre-surgical orthodontics. That is known as a dental arch correction and dental decompensation. Now this is a long phase. This may take 6 months, 8 months, 11 months, 12 months, depending on how severe is the problem. Second stage is your planning for surgery. Once your orthodontics is completed, you start planning for your surgery. How do you plan? You plan it on radiographs. You plan it by doing a mock surgery. And you plan it by making a splint. A surgical splint. So these are the things you plan, you make it, you mark it on a radiograph, you do the mock surgery, which can be done on a cast and it can also be done digitally. I will tell you how. And then you create a splint. What is a splint? Splint is that final relationship between maxilla and mandible which you want during surgery. So you make all these preparations and then you do the surgery. Then you take the patient under GA, you perform the surgery, you put the splint in the surgery and you bring the patient out. After the surgery is over, after the post-surgical phase is over, then again you go back and do the post-surgical orthodontics. This is done for settling. What is settling? That minimum 1 millimeter, 0.5 millimeter discrepancy, because after orthognathic surgery also it is not in millimeters, it is not the exact 0.25 millimeter. So whatever little bit of settlement is required after surgery, that settlement is done after surgery. So that's a very minor phase. Post-surgical orthodontic settling is the last phase. Yes, Srishti, we use braces first. In orthognathic surgery, you don't jump to surgery. First, you put the patient braces, you do the orthodontics, bring the occlusion to a stable decompensated relationship, then you do the surgery. Now, the problem with conventional surgery is that the patient says, I don't want to wait for 1 year. I don't want this 1 year long treatment. Meko to tum abhi karke do. A girl who is about to get married in 6 months, she said that, she says that I want the surgery now. I can't wait for 1 year long orthodontic treatment. For such cases, the surgery first approach is devised. Okay, the surgery first approach has everything except step 1. Okay, it has step 2, 3, 4, but no step 1. So, do you think every patient can undergo a surgery first approach? No. Very limited patients who have very mild dental problems. When the curve of P is not too much, when the occlusal relationship is broadly correct, when incisor relationship is also very mild incorrections, then you can skip step 1. You can directly do step 2, 3, 4. Only very limited indications, which we will discuss at the end. What are the indications for surgery first approach? Only very selected cases can be taken up for surgery first approach. All the other cases, all the severe cases need to follow these 4 steps in this order only. Okay. Dr. Pooja says, man, correcting malocclusion means does the teeth need to be in angles class 1 relationship? As you said, it is not required. Exactly. If a patient has class 3 mandible, you can settle his final occlusion in a class 3 molar relationship. His skeletal relationship needs to be class 1. It should be straight. But molar relationship agar class 3 bhi hai and it is creating a good cusp fossa relationship, it is okay. It is not compulsory to get a class 1 angles molar relationship. Molar relationship can be any. It can be class 2. It can settle into class 3. It is okay. Okay. So here this does not mean, pre-surgical does not mean it has to be a molar class 1 relationship. No. Any molar relationship with a good cusp fossa contact, with a stable occlusion is acceptable. Alright. Dr. Pooja Singh, I hope that answers your question. Okay. So we come to all the things. I will not teach you pre-surgical orthodontics because that is the conventional orthodontics which we do, and that is in the scope of orthodontics. We will start with step 2, 3 and 4. So assessment and planning. We take the patient's photographs. We take the patient's x-rays. Alright. Now what are the x-rays that we need? Broadly we need 3 x-rays. Okay. We need a lateral cephalogram. Remember, I am saying a lateral ceph, not lateral skull. What is the difference between lateral ceph and lateral skull? If you watch closely, the lateral ceph has calibrations. It has a good soft tissue window. I don't know why this is not seen clearly with all of you, but it has calibrations and it has a soft tissue shadow also. Alright, it has a soft tissue shadow, it has a bony shadow, and it is calibrated. So you can make measurements on a cephalogram. That is the basic difference between any plain X-ray versus a cephalometric X-ray. Cephalometric X-ray, it is metric. Metric means there is a meter, there is a scale with which you can mark points and you can make measurements. Alright, so you never go with a lateral skull or a PA skull. You always do a lateral cephalogram or a PA cephalogram because you can calibrate it, you can measure it. Okay, in all cases of orthognathic surgery, you will do a lateral ceph. And the analysis which you do in a lateral ceph is COGS analysis. What is COGS? COGS full form is very, very easy. Cephalometrics for orthognathic surgery. Cephalometrics for orthognathic surgery. COGS or COGS analysis. Very important MCQ asked many times in exam. Who gives COGS analysis? Burstone and Ligan. Burstone and Ligan were the people who started analysis of orthognathic surgery patients on a lateral cephalogram. So it was given by Burstone and Ligan, and we do it in all cases which are going to be taken up for orthognathic surgery. So please remember this. The second X-ray that you do is a PA cephalogram. PA cephalogram is done in cases of, I will write it here, asymmetry. Whenever there is a case of asymmetry, whenever the left and right are not equal, you do a PA cephalogram. Okay, like you can see here, if this is the skeletal nasal midline, this is the maxillary midline, this is your mandibular midline, this should be the skeletal midline, and this is where it is. So there is a deviation of mandible. You can see that this side of the mandible is longer as compared to this side, which is shorter. So there is an asymmetry. Whenever it is a case of asymmetry, you have to do a PA cephalogram. The analysis that you do on a PA cephalogram is a Grumman's analysis. So these two names you have to remember. Cogs analysis done on a lateral cephalogram for all cases of orthognathic surgery. Grumman's analysis done on a PA cephalogram for the cases of asymmetry. Alright. The third X-ray that you do is an OPG. OPG is just done to see the position of the tooth of the third molar, any abnormal teeth, any impacted teeth, like third molars are impacted, sometimes the maxillary canine can be impacted. So to see the dental position, to see the position of the teeth, we do the OPG. Alright, so these are the three radiographs that are used for assessment of a case of orthognathic surgery. Now you have assessed everything, you have done, the orthodontist has put the landmarks, he tells you that the SNA is this much, SNB is this much, you need to take your point A anteriorly, you need to take your gonion posteriorly. So he will do all the measurements, or even the surgeon can do all the measurements. Then you decide your treatment that okay, maxilla 4 mm back, 2 mm up, mandible 3 mm forward, chin 5 mm, and you make a plan. Okay, this is the surgery that I'm going to do. Alright. Then you do that surgery in a mock fashion. You take impressions of the patient, you pour a cast, you do the Facebook transfer, and you articulate the patient's cast. And then you cut the cast 4 mm up, 4 mm back, whatever procedure you need to do, you do it actually on an articulator. And whatever position, so this is the cephalometrics, this is the cogs that is done. Alright, this is the cogs, this is the Grumman's. If required, you do it on a PA cephalogram. And then this is the kind of mock surgery that you do actually. These are real cases from the times I have done PG. Now we do everything digitally. But initially we used to do it on casts. So if you have to take the maxilla up, you actually cut the cast by 4 millimeters, put it up, stick it with some wax or something. Whatever mandibular surgery you want to do, you do it there. And in that corrected position, now you've actually done the orthognathic surgery on the cast. This is a virtual patient. This is an imaginary patient on which you have done the surgery. Now in that correct relationship, you take a bite. You take an impression. Okay. You take an impression and you create what is called as a surgical splint. The surgical splint is also known as a wafer. Why is it called a wafer? Because it should be wafer thin. The teeth should occlude properly and the cusp-fossa relationship should cause the splint to be very, very thin in the place where the teeth are occluding. Other than that, it can be thick so that it doesn't fracture, and you actually create a surgical splint so that when you are doing your actual surgery on the real patient, you have a guide that this much maxilla needs to be advanced, this much mandible needs to be taken back, or whatever is the surgery. That splint will be a final guide of this much movement is required. So this acrylic splint, it's usually made of acrylic, cold cure acrylic, and this acrylic piece is known as a surgical splint or a wafer. When you are doing a single jaw surgery, you make one splint. When you are doing a bi-jaw surgery, that is a maxilla plus mandible, both surgeries are doing, you will make two splints. One splint for one jaw another splint for another jaw. Okay, so you make splints accordingly. So this is how it was made traditionally. Nowadays, everything is done digitally. All the analysis, all the cogs, all the Grumman's, all the 3D planning is done on softwares. Okay, there are many softwares. There is Dolphin, there is everything. Aditi, the user splint I've just told you, in the final real surgery, it will guide you. See, in the cast, you can measure 4 millimeter. But in the real patient, if you have to take the maxilla 4 mm back, yes, there are guides, but still that splint will be your accurate guide that only 4 millimeter movement is possible. Okay, so to bring that actual movement of only 4 millimeter, you fix the splint to the teeth. Okay, and wherever the teeth occlude, that is the movement that you need to do. Understood? So now everything is done on softwares digitally. You take the patient's CT scan. That CT can be CBCT or CT that can be converted into a 3D CT. You can even show the patient by photocephalometrics how you will look after surgery. So if this patient is planned for surgery, he has say a class 3 mandibular relationship, you can perform a mock surgery digitally and you can show the patient how he is expected to look after surgery. And similarly, the 3D splint that we are making, that can also be 3D printed. Okay, just like 3D printing is done for toys and for so many things, you can 3D splint a splint also, 3D print it also. You don't even need to make it physically. Okay. No, Dento Hub 4 mm was an example that I gave. Whatever is your movement, 7 mm, 6 mm, advancement, setback, impaction, whatever is your movement, that's just an example that I'm giving you. Okay. Vinita is asking me what is video cephalometrics. This is video cephalometrics. Cephalometrics along with photography. You can see that the photograph and the radiograph are overlapped. So this is photocephalometrics or video cephalometrics. You can actually do that surgery in the software where the patient can see that my mandible is going ahead or my maxilla is going back. He can virtually see that surgery, the movements of the maxilla and mandible clinically. Alright, that is video cephalometrics. And when you overlap the radiograph with the photo, it becomes photocephalometrics. So this is basically photocephalometrics. Alright. Now, let's look at the equipments which are important. Sometimes image-based questions are asked on the instruments which are needed for surgery. Alright. This one is these are the surgical saws. Okay. They are the oscillating saw. You can see this is oscillating like that. So these are the surgical saws. Okay. This is the conventional micromotor burr, micromotor handpiece and burrs, which we use in most of the cases. First, second and third. This third one, can somebody tell me what is this third instrument? It is the most common image-based question from orthognathic surgery. Can somebody tell me what is the name of this instrument, this third instrument? Anyone? If you can tell me the name of this third instrument, number 3, I'm sure many of you know it. Yes, it is the piezoelectric insert. The biggest advantage of the piezoelectric insert means there is a piezoelectric handpiece, just like your ultrasonic handpiece, and there are different tips. So these tips are known as inserts. And there are different designs. There is a wedge design, there is a chisel-like design, there is a narrow, there is a wide. Different designs are available, and depending on the site of surgery, you can choose your design. The biggest advantage of piezoelectric insert is it does not damage the soft tissues. When we are doing orthognathic surgery, we have to cut the bone. But by mistake, if our burr slips out or if our saw slips, it can injure the soft tissues. It can injure the nerve, it can injure the flap, it can injure the muscles, it can injure the tongue. So soft tissue injury is higher with surgical saws and burrs. Whereas piezoelectric insert, even if you put it on the soft tissues, it will not cut it. Even by accident, even intentionally also, if you put it on soft tissues, it will not cut it. So that is the biggest advantage. It does not damage the soft tissues. So surgery is easy, bleeding is less, everything is good. The only disadvantage that it's very expensive and it is slow. It cuts very, very slowly as compared to burr and as compared to the surgical saw. It is slow in cutting the bone. That's the only, not disadvantage, that is a slight drawback. Otherwise, there are only advantages of using piezoelectric. So remember these as image-based questions. Okay, so before we go on to specific surgeries for mandible and maxilla, Isha, you can ask me a question, and very quickly I am going to show you a video. So this is the sequence of steps that we use in orthognathic surgery. Okay, now imagine this is a patient who has a skeletal class 2 relationship because of retruded mandible. Can you all see? There is a retruded mandible in this patient. Okay. Now, the steps in orthognathic surgery will be, you will put braces for that patient. You will decompensate the teeth. After you have decompensated, you will do the orthognathic surgery in mandible, take it out, maxilla, correct it along with the mandible, and fix it with rigid fixation. This is the kind of change that is brought about. You fix it with rigid fixation plates, treat it just like any fracture, put bone grafts if it is required, and that is the correct sequence of treatment of orthognathic surgery. Okay, I hope you've all understood why we need to do that orthodontic treatment first. Similarly, you can see there is a severe class 3 mandible here. Okay, and you can see the kind of dental compensation which has happened. The teeth are flared. So you need to decompensate it first. Bring the teeth straight like how it should be. Then you do the skeletal surgery. You do a BSSO, you do a Lefort 1, you correct the maxilla and mandible, and then with a stable occlusion, you are bringing the skeleton back to the correct relationship. Does not necessarily mean that it has to be a class 1 angles molar. Okay? It can be a good cusp fossa relationship with good aligner, anterior alignment. Alright? So I hope you've all understood the sequence of steps that we need in orthognathic surgery. Just give me a thumbs up if you're all understanding, and if there are any doubts, you can ask me now. It can be there. Urvashi, it is very, very common to have a class 2, class 3 molar. They can be missing teeth. They can be small teeth. They can be big teeth. So it's very common to have a class 1, class 2, class 3 molar relationship in a straight skeletal profile. It's very common. Tooth ka size kitna hota hai? Itna sab to hota hai tooth ka size. So it's very common. We can have it. Alright. Do we need to remove mini plates? No, we don't need to remove mini plates. That's the beauty of mini plates. You don't need to remove it. Alright. Okay. Now coming back to our orthognathic surgeries. Now we will talk about specific surgeries in mandible and specific surgeries in the maxilla which you should know. The indications, contraindications and everything. Okay. So mandible is slightly tricky. Okay. Maxilla is easy. Mandible is a little tricky. Why? Because the bone is connected to a TM joint. There is a joint which is restricting the movements in the mandible. There is a good muscle envelope. Outside there is a masseter running like this. Inside there is a medial pterygoid running like this. So direct muscle attachments. And which is the most severe muscle attachment here? You know that the masseter on the buccal side and the medial pterygoid on the inner side, they are connected in the inferior border of mandible in the angle region. And in that region, they make a sling which is known as the pterygo-masseteric sling. What is sling? Sling is like a jhula. Okay, it's like an attachment. So masseter here, if I have to make a diagram like this, so on the buccal side, there is masseter on the lateral side. Okay. On the medial side, at the same place, there is a medial pterygoid. And in this region, in the region of angle of mandible, they create a very, very tight tendon, which is known as the pterygomasseteric sling. And this sling is a big restriction to movement of the mandible, especially when you're doing setbacks. If you're pushing the mandible back, this sling will cause it to bounce back forward and cause a relapse in surgery. So this is another problem in mandibles. एक तो वो joint से attached है. So you can't do extreme movements. You have to be very cautious. Second, it is connected to very strong muscles like masseters and medial pterygoid. Third, there is a very, very important neurovascular bundle that is coming from the lingula, which is the inferior alveolar neurovascular bundle. Okay, there is an inferior alveolar nerve, artery, vein which is coming here in the lingula. It is supplying the mandible. It is coming out of the mental foramen here as a mental nerve, and it is running in between the mandible. Now maxilla also has a blood supply, but no vessel is running in between the maxilla. Everything is superficial. Everything is above the maxilla. Mandible mein, there is one neurovascular bundle which is running within the mandible. So these three things make the mandibular surgery slightly tricky. Okay, this is the lingula, this is the inferior alveolar nerve and vessels which enter. Throughout the mandible they run, and in the mental foramen they come out as a mental nerve. So these three things make the mandibular surgery slightly tricky. Alright, keep these three things in your mind. I will tell you the importance as we go ahead. Okay. Broadly speaking, these are the 6 surgeries that you can do in the mandible. Vertical ramus osteotomy, inverted L or C osteotomy, sagittal split ramus osteotomy, body or segmental osteotomy, subapical osteotomy, and genioplasty. This is rarely done. Most of the times we do either 1, 2, 3 or 6. Okay. Just for the sake of table completion, I will write the indications, contraindications, and then we will go to individual surgeries. Okay. Vertical ramus osteotomy. See, knowing the full form also helps you answer a lot of questions. VRO. VRO का मतलब ही है vertical. That means you are doing a vertical cut. Where are you doing the cut? Ramus. And what are you doing? Osteotomy. Osteotomy means cut. Ostectomy means cut and remove. Are you doing an ostectomy? No, you are doing an osteotomy, just a cut. You are doing an intentional fracture, which is known as osteotomy. So just the name will help you answer a lot of questions. Vertical ramus osteotomy. That means it is a cut done on the ramus of mandible in a vertical manner. You can do it via an intraoral incision. If you put an intraoral incision, just like the Ward's incision that we do for third molar, it becomes an IVRO, intraoral vertical ramus osteotomy. If the surgeon is not comfortable in doing an intraoral osteotomy, he will put an extraoral incision. EVRO, extraoral vertical ramus osteotomy. Osteotomy is exactly the same. It is the same osteotomy. What is different? The approach is different. If the surgeon is comfortable to do it from inside the mouth, he will put an intraoral incision and do the surgery intraorally. Then it is called IVRO, intraoral vertical ramus osteotomy. If the surgeon cannot do it intraorally, like when I started my PG, I could not do so much manipulation, I will put an extraoral incision and I will do an EVRO, extraoral vertical ramus osteotomy. So that is the same surgery, just the approach is different. Alright. Subcondylar vertical osteotomy is not the same as VRO. We will come to it, Vinitha. Okay, so this is vertical ramus osteotomy. How do you do it? It's very easy, very easy surgery. You can see the lingula of mandible here from where the inferior alveolar neurovascular bundle enters. Okay, just behind the lingula, you put a vertical cut, straight cut from the sigmoid notch to the angle lower border region of mandible. Straight cut. Easy surgery, just a straight cut. Okay. Now what has this cut done? And you do it bilaterally. Okay. You do it on both sides. Now what this has done is it has split the mandible into three parts. The part which is near the body, basic anatomy, whatever part is near the body, you call it proximal. Okay. So this point part which has the TM joint is known as the proximal part. Please remember this term because I'm going to use this term again and again in my class. Proximal part is the part which carries the joint because it is near to the body's midline. So these are two proximal parts of the mandible now. The part which is away from the body, slightly away, and which carries teeth is known as the distal part, which is the teeth bearing part. So when you do any osteotomy, you kind of split the mandible or you fracture the mandible into a proximal part and a distal part. Two proximal parts and a distal part. Okay. The rule with any mandibular surgery is the inferior alveolar neurovascular bundle should always be in the distal part. It can never be in the proximal part. The inferior alveolar neurovascular bundle should always lie with the distal segment. If by chance you are doing the surgery, your cut has gone a little left-right and your nerve has gone into the proximal part, then you have to very carefully tease the nerve, separate it from the proximal part and bring it with the distal part. It will move with the distal segment. That is a rule in all the mandibular surgeries. This is also a repeat question in your NEET that, you know, the inferior alveolar neurovascular bundle is attached to which segment? Proximal segment, distal segment, either of the segments, none of the segments. So your answer will be always and always in the distal segment. Okay. So your cut will be just behind the lingula. What is lingula? Lingual means tongue. So why do we call it lingula? Why do we call this structure, if you can see here, why do we call this structure as the lingula? Because it looks like a tongue. Okay, this protuberance of mandible looks like a tongue. And from this protuberance, there is a hole from which the inferior alveolar neurovascular bundle goes inside. So that is why we call it lingula. And that lingula is our landmark. For a surgeon, the lingula is the landmark. Lingula say the nerve is going, so you will put the cut just behind the lingula. Okay, so that your nerve is in the distal segment. It doesn't go into the proximal segment. So you do a vertical cut, you push the distal segment medially within the proximal segment and you can do a mandibular setback. Alright, just like any fracture, you will fix it with plates and screws. You can also do an IMF, but if you do an IMF, you'll have to keep the patient's mouth closed for 4-6 weeks. So it's better you can just put plates and screws or just simply positional screws and fix your corrected osteotomy. This is where your splint comes to use. Who was asking me about splint? Somebody was asking me about splint. So this is where your splint. How much mandible do you have to take back? How will you know? Kitna piche leke jana hai mandible ko? When you are fixing your plates and screws here, how will you know how much mandible you need to take back? That splint will be your guide. Whatever decision you have taken in your mock surgery that I will take my mandible back by 7 mm because the need is 7 mm according to cephalometrics, that you can replicate actually in the OT. That splint will guide you, okay, now the teeth are occluding, now you should stop your setback. So only 7 mm setback, it will not become an 8 mm or a 10 mm setback if you have that splint. So this is where splint comes to action. Alright. So the thing is, the proximal segment stays laterally, the distal segment slides medially into it, and you can do very easily, you can do a setback. Alright. We not remove bone, how will we get a setback? Usually in VRO, you don't need to remove a lot of bone. There is an overlap. Okay. There will be no step deformity. The soft tissue envelope which is there. I like the kind of questions that you guys are asking because they are very, very clinical questions. Okay. The soft tissues which are there over the mandible, the masseter, the buccinator, all these muscles, they will kind of not make the patient feel the step. And in some time, the mandible will remodel. So there is no actual step. That is a problem. All right. The splint should be worn by the patient while surgery. Surgery, patient is under GA. He doesn't wear it. The surgeon puts it there. So yes, the surgeon puts the splint there during surgery. All right. Usually we don't have to remove bone. Why? Because just like I said, for a stable surgery, for your surgery to be stable, you want your surgery results to stay as it is. You don't want that when the patient wakes up from GA, his surgery results are lost. Do you want that? No, you don't want a relapse. You want a stable surgery. So what are the requirements of a stable surgery? Good occlusion, which we have achieved with a pre-surgical orthodontics. And second requirement is good bony overlap. Very, very important. The more is your bony overlap, the stable is your surgery. You must have read in your questions that a maxillary widening is the least stable surgery, because as soon as you widen your maxilla, there is a gap. There is no overlap. So you don't remove bone here. You actually overlap the segments. The more is your overlap, the better is the result of your surgery. The more stable is your surgery. On that note, please tell me, can you do an advancement with a vertical ramus osteotomy? Will you choose vertical ramus osteotomy as the surgery of choice when you have to do mandibular advancement? Yes or no? I'm taking this break to listen to your answers. No, very good. Because if you use VRO for advancement, it will create a gap. And any surgery with a gap is an unstable surgery. All right. The question that when you do it, when you push it medially, does it hamper the muscle attachment? Very mildly. Because you're not doing it to an unlimited extent. You're doing it to a limited extent. So for a limited extent, you can do setbacks with not much problems to the muscle. All right. So coming back to the table, the indications of vertical ramus osteotomy is large setbacks. You can do large setbacks with vertical ramus osteotomy. What is the limitation? Advancement. You can't do advancement with VRO, because if you do advancement, it will cause a gap between the proximal and distal segment, and it will cause an unstable surgery. Even if you put a bone graft there, why do you need to do VRO? You can do other surgeries which are creating a overlap. So advancement, mandibular advancement. All right, we are talking about mandibular surgeries. Mandibular advancement, you will not do with VRO. For setbacks, it's a very good surgery. For large setbacks, for open bite corrections, whenever there is an open bite which needs to be corrected along with a class 3 or class 3 mandible, open bite, very good. You can use vertical ramus osteotomy. Third indication is when there is a temporomandibular disorder. What is temporomandibular disorder? We will read it when we are doing TMJ. But whenever there is a pre-existing joint problem, the VRO will help in correcting the joint problem. Okay? It will kind of sag the condyle a little bit to a certain extent, and it will help in correction of TMD. So these are the three indications. These are the three indications of vertical ramus osteotomy. And what are the limitations? You cannot do advancements. Second is in recent condylar fractures. Whenever there is a recent condylar fracture, you usually wait before doing VRO, because then all the pressure comes to the condyle, all the torquing forces come to the condyle, and you don't really want to give so much force to the condyle. So these are certain limitations or cautions that you need to take in doing a mandibular surgery and doing a VRO. As we give incision, is there any indication? This is all, we will come to it. All right. Sigmoid notch में तो आप incision दे ही नहीं रहे हो ना दर्शना. You're not giving any incision in the sigmoid notch region. You are just doing a vertical cut. So why will there be any injury to the nerves and vessels in the sigmoid notch? Of course, if you are a very careless surgeon and if you are cutting with a burr like that, you can injure anything. But generally, there is no injury to the blood vessels in the sigmoid notch region. All right. So this is the first surgery, which is the vertical ramus osteotomy. Now, people thought that what can we do to bring an overlap in the segments? So this is one case where a EVRO was done. I will just show you this case and then we'll move to the other surgery. This is a severe class 3, as you can see here. This is the soft tissue profile of the patient. This is the soft tissue nose. This is the bony nose. This is the upper lip and this is where the lower lip is. I want to take the mandible back to a large extent. So like 8 to 10 mm of setback. So it's a large setback. What will I do? I will do a vertical ramus osteotomy. So this patient, I've done the pre-surgical orthodontics, I've done the cephalometric planning, I've done the photocephalometry, I've done the prediction that this is how the patient will look after surgery. And this is the surgery. I'm going to show you the actual steps of surgery of an EVRO. We have done an extraoral incision, which is the submandibular incision. We have opened up. You can see this is the patient and this is the ramus. Orient your eyes like this, okay? This is the mandible. This is the ramus that all of you are seeing, all right? Now, I have done a vertical ramus osteotomy like this, which you can appreciate here in this image, all right? I hope you can all see the vertical ramus osteotomy which is done. All right. Now I will use my splint. This is my splint to guide me how much I need to take the mandible back. Okay. I will use that splint. I will fix it with some wires and I will, whatever movement I have done, I have taken the distal segment back and glided it medial to the proximal segment. And I have fixed that with 2 positional screws, which you can see here. And I have closed the extraoral incision with sutures. Alright, so these are all the steps of EVRO. And you can see it on the post-operative OPG also. This is the post-operative OPG. You can see the 2 screws that are used here and here. You can see, if you watch clearly, you can see the vertical osteotomy also. Can you see that black shadow there? This obvious osteotomy which is there here. I'm not putting a line on the osteotomy because then you won't be able to see it. This osteotomy, right? I hope you can all appreciate it. Yes? Can you all appreciate this white black line there? This osteotomy which is there here and here. Pooja can't understand. Pooja, can you see this vertical ramus osteotomy line? This line on both sides here also. This line. And they are fixed with 2 screws. Alright, it's okay if you can't see, don't worry. Just understand that a vertical cut has been done. Yes, most of you can see it. Good. Alright. And this is how you have corrected a severe skeletal class 3 into a skeletal class 1 profile. Okay. This is the post-operative result. How after orthodontic compensation, there was a severe reverse overjet. Then after surgery, it has come back to a very correct overjet and overbite. Alright. So, these are the corrections that you do after a VRO. Alright. Okay. Now we come to inverted L or C osteotomy. Now the surgeons thought that, why don't we give an overlap? So just to create that overlap, they have given a horizontal osteotomy on the ramus, followed by a vertical osteotomy. So that becomes a straight L, inverted L. So this is an inverted L osteotomy. And if you convert it like this, instead of a angulated osteotomy, if you give it like this, it becomes a C osteotomy. Alright. So there are a lot of modifications. You can give it from up, you can give it from down. different shapes. But broadly speaking, this is the osteotomy. And tell me, which segment will carry the inferior alveolar neurovascular bundle? Proximal segment or distal segment? Which segment should be carrying the inferior alveolar neurovascular bundle? Nishit, the setback happens when you actually go for the surgery. You will see that you can easily slide it medially. Very good, Kiruthik. In the distal segment, you will have the neurovascular bundle. I'll be revising the same things again and again so that you remember it nicely. Alright, so inverted L or C osteotomy, not very popular. Broadly, it is used for open bite cases. Broadly, the indication of inverted L osteotomy is open bite cases. Very good. I'm very happy that most of you know that it is the distal segment which will have the inferior alveolar neurovascular bundle. Again, the caution with inverted L osteotomy is advancement. Although there is some overlap which happens when advancement is done, but it still creates a gap. And it's not the best surgery for advancement. So you will not use it for mandibular advancement. Alright. Next we come to BSSO. Alright. So we come to BSSO. The full form is sagittal split ramus osteotomy. Sagittal split ramus osteotomy. Which is, if you've done the same thing bilaterally, if you do the sagittal split osteotomy of the ramus, it becomes a bilateral sagittal split osteotomy. Okay. So as the name suggests, it is a sagittal osteotomy. One MCQ solved. What kind of mandibular surgery cuts the mandible sagittally? SSRO. Which part of the mandible is split sagittally? Ramus. So 2 MCQs are solved here. What is the kind of split that you do? Sagittal split. What is the meaning of sagittal? Sagittal means antero-posterior split. Alright. In this, inferior alveolar nerve won't get injured? No. When done properly, the neurovascular bundle doesn't get injured. Advancement means taking the mandible forward. Setback means taking the mandible back. Alright, Dr. Aditi, is that clear? There is no damage to the inferior alveolar nerve, so don't worry about it. Okay, so if you cut the mandible like this, it's a vertical osteotomy. If you cut the mandible like this, it is a horizontal osteotomy. But if you cut the mandible and split it like this, like antero-posteriorly, you put a medial cut horizontally, you put a vertical cut buccally, and the medial and vertical cuts, you connect it sagittally. So you kind of split the mandible and open it up like a book. This is the beauty of a BSSO or an SSRO. You are splitting the mandible. You're not exactly dividing it into a posterior and anterior segment. You are actually kind of splitting it and opening it up in an antero-posterior direction like a book. So even if you do a setback, there is an overlap. Even if you do advancement, there is an overlap. All right. So, Dr. Nishit, in your BSSO, when you do a setback, we do remove bone. When we are doing a BSSO setback, we definitely remove a part of the bone that you are setting back. That much setback, we remove bone. Alright? In VRO, you don't need to remove a lot of bone. You can trim a little bone to slide it inwards, but you don't really remove bone. In BSSO, yes, since you are sliding it antero-posteriorly, you have to remove bone. Is that clear, Dr. Nishit? Okay. So, there are 3 cuts which you give in BSSO. You can't just split the mandible just like that. You need to put proper cuts. You need to put proper osteotomies before splitting the mandible. Okay. There is a history of BSSO also, but finally I will be telling you the conventional BSSO that we do now. The first cut that we do is a medial horizontal cut. You can see it is on the medial side of the mandible and it is horizontal in direction. So the first cut that you do is a medial horizontal cut. And where do you put that cut? Just above and just posterior to the lingula. You can see this lingula here, just above the lingula and just posterior to it. 2 or 3 mm above it, 2 or 3 mm posterior to it. Just till there. You don't do a complete cut. It's not a complete medial cut. It's a partial medial cut. Okay, you do a half cut just above the lingula and till just posterior to it. Alright, so that's the first cut. The second cut that you do is a buccal vertical cut. This is a stop cut. Okay, this cut is going to stop the fracture. It is going to stop the osteotomy from converting into a fracture. So this is a vertical stop cut that you do on the buccal side, on the labial side. Okay, this cut. Okay, this is done just distal to the second molar tooth. Okay, this is done just distal to the second molar tooth. The third cut is a sagittal or an antero-posterior cut which connects the first and the second cuts. Alright, it might sound difficult, but when you actually observe the surgery, you will understand better. For now, to understand on theoretical point of view, just remember that there is a third cut which kind of connects the two cuts like this and kind of opens the mandible in an antero-posterior direction. Alright, so this is the third cut, which is the sagittal cut, antero-posterior cut. Now, although you are doing a buccal cut in the body of mandible, but still most of your osteotomies are in the ramus. Most of your osteotomies are in the ramus of mandible. So that is why it is called a sagittal split ramus osteotomy. Alright. Remember these three cuts, the position of the cuts, the direction of the cuts, and that is what is asked in the exam. Again, the neurovascular bundle will go into the distal segment. Now this becomes your proximal segment. This becomes your distal segment. Whether you want to advance the mandible, then also there will be overlap. Whether you want to set back the mandible, you can remove a little bone and set back the mandible. Then also there will be a very good overlap because of that sagittal cut. Even if you correct for asymmetry or for open bite, any movement that you do with BSSO, there will always be a good overlap between the proximal and the distal segment. That is why BSSO is known as the workhorse of mandibular orthognathic surgery. It is known as the workhorse of mandibular orthognathic surgery because all movements of mandible are possible with BSSO. Doesn't mean you can do any amount of movement. No. Depending on the situation, you can do movements, but all kinds of movements. You can do advancement, you can do setback, you can do open bite closure, you can do asymmetry correction to some extent. Okay, what is the depth of medial and buccal cuts? 1 cortex deep. You just have to cut 1 cortex and reach the medulla. Alright, 1 cortex deep cut should be there. Alright, you just have to cut the cortex. It's a corticotomy that you have to do. So that's the answer. Prashams Chandra. Alright. So this is BSSO. Now what all questions are asked around BSSO is, what if there is a third molar there? What do you do with the third molar? Suppose there is an impacted third molar here. What do you do that in that case? Alright. So in that case, you can do 2 things. Conventionally, the old school of thought says that extract the impacted third molar, 6 months before surgery. If there is an impacted third molar in your mandible, remove it 6 months before surgery. That when you are doing your orthodontics, that time only you extract that third molar. Okay, so that in 6 months there is good bony healing, there is bone formation, and your cut is proper. All right, so that is one school of thought. Other school of thought is extraction at the time of surgery, and both are correct. Some surgeons, they consider the impacted third molar as bone. They cut through the impacted third molar, do the movements, and before fixation they will remove that tooth. So that is also okay. Both are okay. Alright, conventionally the impacted third molars are extracted 6 months before surgery. Some surgeons remove it at the time of surgery. Alright, there will be no step deformity in any movement. Because there is a good muscle envelope, I am answering this question for the second time. Whatever orthognathic surgery you do, whatever step is created, it's not a step which creates a problem in function. And it's not a step which creates a problem in cosmetics. It is camouflaged by the soft tissues. This is the bony movement. Uske upar muscles hai na? Uske upar soft tissue envelope is there. Alright? So, there is no problems. What is the disadvantage of the second school of thought? I never said there was a disadvantage. Both are absolutely correct. You can do both. You can extract it at the time of surgery or you can do it 6 months before surgery. Both are correct. Alright. So this is a medial horizontal cut, which is the first cut, just above and just posterior to the lingula. A buccal vertical cut, just distal to the second molar, and a sagittal cut, which is anterior-posterior. Don't worry, I will show you videos so that you understand it even better. Alright. So coming back to our table here, BSSO indications advancement, setback. What is advancement? Taking the mandible forward. What is setback? Taking the mandible back. It can be used for open bite. It can be used for asymmetry. It can be used for all kinds of cases. Alright. The only caution is you have to take care of the joint, you have to take care of the pterygomacetrix sling, and you have to take care of the nerve, neurovascular bundle. Just take care of all the structures, and it's the best surgery. It is the workhorse of mandibular orthognathic surgery. Alright. So what is the maximum advancement do with BSSO? That depends on the patient to patient. If it is a small patient with a small face and a small mandible, you can do small movements. If it is a large khali patient who is very giant, has a big mandible, 12 mm advancement possible, you can do major advancements. So nobody is going to ask you the maximum advancement or the maximum setback. That depends on the size of the bone. That depends on the size of the mandible and size of the maxilla. Okay, so that is not, you don't do it unilaterally, Nishit. All these surgeries are done bilaterally. Okay, either you do a bilateral sagittal split osteotomy. Some people, article based if I talk, they have done a USSRO also. That is a unilateral sagittal split osteotomy. Just to correct the asymmetry. It looks like Dr. Nishit is an oral surgeon already. A lot of oral surgeons do attend my classes. And Dr. Nishit, you sound like an oral surgeon because never ever a student has asked me about USSRO. You're the first one. So welcome to the session. Yes, some articles do mention USSRO for minor asymmetry corrections. The limit of asymmetry correction with USSRO is just 2 to 3 mm. And yes, it can be done, but it's not very popular. It's not important for NEET or INI, so I'm not discussing it. But USSRO, that is unilateral sagittal split osteotomy, is also done for minor asymmetry corrections. The only drawback is that it causes some torsion on the opposite condyle, on the opposite joint. So we don't have the long-term data of the results. All right? Okay. Coming back to NEET. From articles, we are coming back to NEET. Now we come to the next surgery, which is the body or segmental surgery. As the name suggests, it's a surgery done in the body of mandible. Till now, whatever surgeries we have done, whether it is VRO, whether it is inverted L or BSSO, these surgeries have been done in the ramus of mandible. Body osteotomy, also known as segmental osteotomy, is done in the body of mandible. Okay, subapical osteotomy also done in the body of mandible, and genioplasty, it is done in the genial region, that is the anterior mandible between the mental foramen. Okay, it is the anterior mandible between the mental foramen. So remember which surgery is done where. Now body osteotomy कैसे करते हैं? Let's jump to body osteotomies. There are other things about BSSO also which I will discuss. First, let us finish all the surgeries. So body osteotomy, you create a space for the cut or a space for the osteotomy by extracting one or two teeth. If there is a space available by orthodontic movement, very good. If there is no space available, you extract a tooth and you create a space for osteotomy. You perform an osteotomy in the body bilaterally, and only that segment of mandible will move. Full mandible need not move, like in this case which I showed you initially. This patient has a normal posterior occlusion. Only the anterior mandible is a problem. So I will extract two premolars, create a space for osteotomy, put two cuts in the body of mandible and close the bite. Alright, so you can close your bite. So open bite cases mostly you use the body osteotomy. What is the drawback or what is the disadvantage? Let's go back to the table. So it is done for mainly open bite cases or segmental deformities. What is the drawback? You can cause devitalization of teeth. So if you are not careful with your osteotomy, if your osteotomy goes into one of the teeth, you can devitalize that tooth. Alright. Also, you can cause a segmental necrosis. If you're not careful about the blood supply of that segment, if you don't take care of the soft tissues, you can cause a segmental necrosis also. So these surgeries are not very popular in the European and American countries. But in India, I have still seen cases of segmental osteotomies. In the US and UK, they are not very popular because the risks are slightly high. Indian surgeons are slightly more courageous, maybe. And I've seen segmental surgeries in India, but not very popular. You can do the same correction with BSSO also. Alright, so you avoid these surgeries, but the indication is broadly open bite and segmental deformities. Subapical osteotomy also similar to it. Basically, you are cutting, instead of a body osteotomy, in subapical osteotomy, you are cutting it below the apices of teeth. From the last tooth on one side to the last tooth on other side. You are cutting it beneath the teeth. Okay? And only the dental segment is being moved. Only, this is the subapical osteotomy, which is going to change only the dental segment. It will not change the bony segment completely. Alright, so जब यही करना है तो orthodontics कर लो. So again, it's not very popular. The same drawbacks as they were there in body osteotomy, only dental changes can be done. And same problems, devitalization of teeth, because if you cut near the apices of teeth, you can devitalize the teeth. So that's a big problem. Alright. And the last surgery in mandible is genioplasty. Okay. Genium is this region of mandible. We know this is the genium. Any surgery, all movements are done. Very nice surgery, very easy surgery. Advancement, setback, go up, go down. You can use bone grafts here. With bone grafts, you can do a double sliding, double additional augmentative genioplasty. All kinds of movements are possible. And remember, genioplasty can be done with any other surgery also. That means you can do a BSSO in the ramus with the genioplasty. You can do a vertical ramus osteotomy with the genioplasty. Alright. So, you can do all movements with genioplasty also. Alright. Very quickly, I will show you genioplasty. So, anterior to the mental foramen, you will put cuts. No changes in occlusion with genioplasty. It is very easy. I've done it under LA also. You can sit the patient on the dental chair. Usually we do it in combination with other surgeries. This is a chin plate, which you can see. It's like a step kind of a plate. And whatever movements you have done, you can adapt your plate accordingly and fix your osteotomy. Many image-based questions are asked on genioplasty. So please fix this image in your mind. Please don't make notes if you're making. Every image is there in your notes. So just revise these images from your notes. Don't write it. Okay, so this is a clinical picture showing you genioplasty. This is a post-operative picture showing you the chin plate and this genioplasty cut, which you can see going from here to there. This is a lateral ceph, post-op lateral ceph showing you genioplasty with advancement. You can see the advancement which is done with genioplasty. Here it's a PSF which is going to show you how asymmetry correction is done with genioplasty. Okay, so a lot of image-based questions are coming from genioplasty. So remember these cuts, remember these plates, and this completes all the types of orthognathic surgeries that are done on the mandible. Few special points I want to tell you about BSSO. Alright, there are some special points which are very, very deep, which are the SR level questions. But since they have been asked previously, I would want to tell you these questions also. The first thing is fixation. So when you are doing a BSSO, whether you are doing an advancement or you are doing a setback, okay, there will be some areas where the bones will be contacting absolutely, okay, but there will be some areas where there will be slight gap, okay. If I show you like this, okay, this is my proximal segment, this is my distal segment. When I am doing my mandibular advancement, because the mandible is not a straight bone, right? It's not a straight bone. It's a bone with a flare. It's a boomerang shaped bone, and you can see that there is a flare in the mandible. It's not an absolutely curved bone. It's curved with a flare. Alright? And because of that flare, when you advance your mandible, in some regions in the posterior area, there will be contact between bone. But in some regions, there will be a slight gap. It does not mean that there is no overlap. There is still an overlap, but there is a slight micromechanical gap, or maybe even a macro gap. So whenever you are doing a fixation of your BSSO, whenever you're putting plates and screws, either you put mini plates and screws, then there is no problem. But when you are doing a screw fixation, only screw fixation, in the gap areas, you have to put positional screws. And in the contact areas are also known as the neutral position. In the neutral position, which is the contact area, this area, the best screw is lag screw. What is lag screw? What is positional screw? That you will know when we are learning trauma. Okay, just for now, just remember, whenever there is a gap, so in advancement, there is a gap anteriorly and the neutral zone is present posteriorly. So the best fixation in the neutral zone is a lag screw. And the best fixation in the gap area is a positional screw. Similarly, when you are doing a set back, you can see the mandible is being set back. When you are doing a set back, the anterior areas have a contact and it's the neutral position. And the posterior areas may have a gap. So, in the gap areas, you will put the positional screws. And in the contact areas, you will put the lag screws. Just remember it as a fact for now. When you do trauma, you will understand what is gap, what is lag, and what is positional screw. Alright? Yes, you cannot do a transverse movement in the mandible. For transverse movement, you have to do distraction. You cannot do a transverse movement easily in the mandible. Alright? Shivanki, that answers your question. Okay. Tahir, how to manage the frenum? Frenum to yahan par hai beta. Frenum is in the tongue. Genioplasty you are doing here in the bone. There is no relationship between genium and frenum. Alright? They are never in contact. So this is one thing. The fixation in BSSO is sometimes asked. It's an SR question, but it has been repeated in NEET. Next thing is certain special instruments. What do you use to actually split the mandible and cause a sagittal split? Okay. You can use a T spreader This instrument is known as a T-spreader, or more commonly you use this instrument which is known as a Smith spreader. Can be asked as an image based question. So please remember, this is a Smith spreader. Alright. So these are two special instruments used in BSSO which can be asked as image based questions. Okay. Next, one thing which I want to tell you about BSSO is, I will write it here. Okay. Before complications, I want to tell you about the history of BSSO. Only once they have asked this question, but I think you should know certain names in BSSO that tell you the history of BSSO. Okay, if you are thinking that is it really important, it's not very important, but it's good if you know certain names. Schuchart, Trauner and Obweiser, Dalpont, Hansak, Epker and Spizel. Bell. Between Epker and Spizel there was AO also. It's not a person, but it's an organization, so I've wrote it separately. So BSSO is one surgery which has really evolved over the time. Okay, the first person who gave BSSO was Schuchart. Okay, instead of a horizontal and a vertical cut, he gave two horizontal cuts and connected them sagittally. Okay, instead of this and this connecting sagittally, he did two horizontal cuts and connected them sagittally. So that was the first BSSO done by Schuchart, and he fixed it in, initially there was no plates and screws. Initially when orthognathic surgery was evolving, there was no real plates and screws. So he used it with wire fixation. He fixed it with wire. Then Trauner and Obweiser, what they did, they increased the distance between the cuts. They just increased the distance between the two horizontal cuts by 25 mm. Dalpont modification. What is Dalpont modification? He brought the buccal cut vertically. He was the one who introduced the vertical cut. And what was the position of this vertical cut? It was between the first and the second molar. What did Hansak do? Hansak said, okay, you do the vertical cut, but don't do it between first and second molar. Do it distal to the second molar. So he brought the vertical cut at the angle of mandible. That is distal to 7. That was the Hansak modification. Now, what does Epker do? Epker said that a lot of times when they were doing this BSSO, there was a complication known as a bad split. And Epker said that bad split can be avoided if you do a buccal inferior osteotomy. Don't try and understand it to a great detail. Just remember these facts. That will be more than enough. Just remember these facts as it is. He brought the buccal inferior osteotomy. He said that when you are doing a vertical cut, take it slightly inferiorly also, so that there will be no bad split. That was the Epker modification. Then AO came. Till now, all the fixations were done with wire. Now AO came and AO said, please do fixation with plates and screws. That was the AO modification. Plates and screws for fixation. Then came Spizel. He said, don't use burr, use saw. He said, instead of using a burr, use a saw. That will be more safer. And the last, Bell, he said, use rigid fixation. Rigid fixation was again forms of plates and screws. So this is the history of BSSO. One time they have asked about, one of the people that what is the Schuchart or who gave the BSSO for the first time. So I thought I will tell you the history of BSSO also. Not very important, but you should know how this surgery has evolved, because this is a very, very important surgery. It's the workhorse of mandible. Okay. I know the session is going very long. I will quickly show you the complications and then I'll show you 2 or 3 videos. The first complication that can happen with BSSO is this bad split. You can see this X-ray where the split has gone anteriorly. It can split the condyle, it can split the anterior mandible badly. Okay, so to prevent bad split, prevention, what is the prevention? Do the inferior buccal osteotomy. If you do an inferior osteotomy, chances of bad split are less. Extract your third molars 6 months before surgery. Chances of bad split will be less. The other complication, second complication that can happen is inferior alveolar neurovascular bundle going into the proximal segment. If that happens in your osteotomy, tease it and bring it to the distal segment. The third complication that can happen, which is asked sometimes, is condylar sag. There are 2 types of condylar sag, central and peripheral. I will not go into details of it because that will be too much. Just remember condylar sag. Now, what is condylar sag? When you are doing the surgery, the patient is unconscious. He is under general anesthesia. He is under the effect of muscle relaxants. All the muscles which are attached to the TM joint are relaxed. Now, when you cut your mandible, okay, when you're doing a BSSO, you're pushing the mandible behind, you're pulling it ahead, you're doing a lot of movements. So it's not just the distal segment which moves. Sometimes there is an effect on the proximal segment also. वो भी तो थोड़ा बहुत खींचेगा ना, थोड़ा खींचातानी होगी, proximal segment भी नीचे जाएगा. So what happens is, intraoperatively, the condyles come slightly out of the fossa. Instead of a proper cusp, glenoid fossa and condyle relationship, the condyle comes slightly down. What is the problem? Now you have fixed your osteotomy in that abnormal condylar relationship. Okay, condyle properly should have been seated like this, but it has come down. You didn't take care of the condyle and you fixed your osteotomy. So when this patient will get awake from surgery, when the effect of GA will be gone, when the effect of muscle relaxant will be gone, the condyle will go back to its fossa because you can't stop the condyle from going into the centric relationship. The condyle will go back and the result of your surgery will go bad because you have fixed it in one relationship, now the condyle has moved. That will cause a post-operative open bite, a post-operative malocclusion. So your results of your surgery will be bad. Okay. What is the prevention? Very easy prevention. Lot of instruments, lot of devices were, invented to keep the condyle back. Ultimately, it is a very simple thing. Ask the assistant to put a thumb under the condyle and push it before fixation of your plates. Alright, so before you fix your plates for orthognathic surgery, let me just put my laptop into charge. Yeah. So before you actually put those plates and screws, just ask your assistant to give some thumb pressure under the angle of mandible to put the condyles back into the fossa. Once you've put the condyles back into the fossa, then only you should do your fixation. Very easy. Very important MCQ that is asked in the exam. What is the easiest, simplest and most popular method of preventing condylar sag? Answer is thumb pressure at the angle of mandible. Alright, that's the third complication. The last complication that can happen is which is chin deformity. Which surgery causes this complication? Genioplasty. What happens in genioplasty is you give an intraoral incision, you strip off all the muscles, mainly mentalis. You strip off the mentalis muscle, and when you finish your surgery, you need to put the mentalis back and stitch it there. If you forget to stitch it there, the mentalis will sag, and your patient, in spite of a good surgery, he will look like a witch. A witch looks like a very long chin, like this, a sagging kind of a soft tissue. You can see this celebrity also with that witch's chin deformity. All right. So how will you prevent that? You can prevent it intraoperatively when you're doing a surgery. At the end of surgery, you should suture your mentalis. So this is called soft tissue resuspension. You have to resuspend your soft tissues back to the correct position. If you do that, and post-operatively, you should put a tape dressing. You can see this kind of dressing. It's called a tape dressing. A tape dressing on the chin. You leave that chin part because you have done your surgery there. But above and below it, you put a tape so that whatever soft tissues are there, they get adapted to that new position properly. All right. So witch's chin deformity is a complication of genioplasty. How will you prevent it? While closure, you will do a good soft tissue resuspension and you will do a tape dressing. All right. Just give me a thumbs up if you have understood everything about mandibular orthognathic surgeries. And I will show you the videos also. Just give me a thumbs up if you've really understood everything. So this is a BSSO setback. All right. I have done osteotomy. I will remove a part of the mandible and I will set back my mandible. So I've done the BSSO and now I have done advancement. You can see how sagittally it is split and how a good overlap is there between the bones. Once again, if you want, I will show it once again. This is a BSSO setback. We have done the osteotomy. We have removed a part of bone for setback. This part of bone we are removing and then we are taking the mandible back. This is BSSO setback. Now we are doing advancement. This is how you slide the mandible sagittally. Alright, you can see how nicely there is a sagittal cut. You can see there is a sagittal, that is an anterior-posterior cut. And even with advancement, there is such a good overlap. Which is why BSSO is one of the safest and the most stable surgeries in mandible. Alright? Okay. This is one case of genioplasty from my PG times. I somehow have this as a record. So you mark the points, that a vertical reference mark, so that you know how much you have to advance. Okay, I will do it slightly faster. These are the reference marks that we are marking, so that you know how much advancement you have to do with that reference point. In genioplasty, you cannot make an occlusal splint because occlusion is not involved in genioplasty, right? So you make the vertical reference marks and from that you can calculate how much advancement or setback. Now you can see that I am doing it's not done by me, it's done by my HOD, how a horizontal osteotomy is done in the chin region. Okay, I'll just fast forward it slightly. There's a horizontal osteotomy. And finally, I'm splitting that osteotomy with a chisel and mallet. The final cut is done with a chisel and mallet. This is how I'm splitting. And this is how the chin segment is now free. You can see that genial segment is now absolutely free and mobile. Okay. Now I'm taking that plate and the assistant is usually supposed to adapt it. This is the chin plate, which I'm adapting according to the amount of advancement that I have done. Okay, and then I'm fixing that chin plate there. I've done the advancement of the lower segment. I am fixing the plate there with burrs. I'm drilling a burr hole and in that burr hole, I will fix the screws. Right? So this is the first screw that is gone. I am holding the chin with a wire. I mean, somebody is holding it and we are drilling holes and we are putting screws so that that plate is going to hold the chin in the correct position. All right. You can see here that when this surgery is done, all the muscles, mainly the mentalis muscle which is there in the chin region, all that muscle is stripped off. So if you don't put that muscle back, your chin will sag and will cause a witch's chin deformity. So at the end of surgery, when all the screws are fixed, I'm just fixing the screws with a screwdriver. When everything is done, I will put the soft tissues back. I will suture my mentalis muscle properly and I will put a tape dressing. All right. So this is how we do a genioplasty. All right. I hope everybody of you have understood and you are taking this home back. I know it's been a long class, But very quickly, I will also finish the maxillary orthognathic surgeries and then I will give you a short break. Alright? Maxillary surgery में कुछ नहीं है. There is only one surgery, Lee Fort 1 osteotomy. And this is the workhorse of maxillary orthognathic surgery. Yes, you can do a Lee Fort 2 surgery, you can do a Lee Fort 3 surgery, but very, very rarely. Most commonly, you do a Lee Fort 1 osteotomy. Alright? And that is the workhorse. Why? Because you have seen an aeroplane, right? All of you have seen an aeroplane and you have seen a helicopter also. Alright? I know thoda saturation ho raha hai, ab aap log thak rahe ho, but we will have to finish this because of the time constraints. The difference between an aeroplane and a helicopter is that helicopter can just go up and down and straight. Okay? It can go up, it can come down and it can go straight. Or maybe it can come back. It cannot tilt. Whereas an aeroplane can, just take off in a slanting way, go down. Those who have seen this Republic Day parades and Independence Day parades, right? You've seen that how they do this acrobatics in the aeroplane. They turn the aeroplane and they tilt it left. All of them tilt to the left. All of them tilt to the right. And they do this nice air show in the Republic Day and Independence Day parades, right? Because the aeroplane can do a pitch yaw roll. The aeroplane can go like this. It can go left. It can go right. It can roll also. That is why the movements of maxilla are compared to the movements of an aeroplane. I will quickly show you a video once more and show you how you can compare the maxillary movements with the aeroplane movements. So if you do a vertical positioning of the maxilla like the last image, it is a pitch correction. Just like the aeroplane can go down and it can go up. Just like that, you can tilt your maxilla up and down. This is known as the pitch correction. Similarly, the aeroplane can go left and right. And you can also take your maxilla left and right whenever there is a midline problem. So you can yaw your maxilla. And the topmost image is a roll. You can roll your aeroplane also. If the pilot is a little crazy, he can roll the aeroplane like that. And similarly, when your maxillary occlusion is slanted, when there is a canting in occlusion, you can also roll your maxilla just with one surgery. And that one surgery is Lee Fort 1 osteotomy. Exactly the same as Lee Fort 1 fracture. The only difference is fracture is accidental and osteotomy is done by us. Alright? So this is the pitch yaw roll. I will show it to you again. So whenever you have to correct the anterior-posterior relationship of the maxilla, okay, you do a pitch correction. You can see this girl, there is hardly any incisal show. You want to increase the incisal show. You will increase the pitch. You will bring the maxilla down. On the other hand, this girl has a vertical maxillary excessive vertical show of the maxilla. You will reduce the pitch. You will take the maxilla up. So this is the pitch correction. Which surgery will do it? Lee Fort 1 osteotomy. Coming to the other set of pictures. Now this is the skeletal midline of the patient. And this is the maxillary midline. Not coinciding with the skeletal midline. Occlusion is okay, but midline is not coinciding. What you need to do is shift the maxilla to the left. Here, this case also, this is the skeletal midline. This is the maxillary midline between the central incisors. Now, orthodontics is not a problem. The teeth are aligned. Everything is good. There is no spacing, there is no crowding, there is no malalignment. There is just a midline shift. This correction of midline, just shifting the maxilla, rotating the maxilla left or right, this is known as yaw correction. Okay? Midline correction is known as yaw correction. The third set of things is the plane of occlusion. Normally, in normal people, in you and me, the maxillary or the mandibular occlusal plane is parallel to the interpupillary line. Obviously, people who are congenitally deformed with abnormal eyes, we are not talking about them, we are talking about normal people. The interpupillary line and the occlusal plane is usually parallel to each other. But if you see this patient, if you see her carefully, you will see that, these teeth are slightly up and these teeth are slightly low. So this is how her occlusal plane is. It is slanting. There can be many reasons. It can be because of ankylosing, it can be because of hyperplasia, it can be because of some maxillary tumor, many reasons. Let's not go into the reasons. There can be many reasons for this slanted occlusion, which is known as canting or slanting of maxillary occlusal plane. So I will say that this plane midline is also correct, articulation is also correct, cusp foci is also correct, everything is correct, just the plane of occlusion is tilted. This is known as canting of occlusion. How will you correct this canting of occlusion? Roll correction. You will roll the maxilla up, you will remove some bone from here, you will put the maxilla up, whatever bone is, whatever space is created on this side, you will use this as a bone graft on the other side and correct the occlusal plane. This is known as roll correction. Similarly, in this patient, see, this is the interpupillary line. Yeah. So this is the interpupillary line. Okay. And this is the plane of occlusion. So all you need to do is roll correction. Alright. So I hope pitch, your roll and is clear to all of you. Okay. Type down pitch if everything is clear to you. Type pitch in the chat box if the pitch, your roll is clear to all of you. Alright. So this is very, very simple. Leafort 1 osteotomy. You put an incision, intraoral incision. This surgery is always done intraorally. You put an intraoral incision from the first molar on one side to the first molar on the other side. Okay. When you put an incision, alright, thank you so much for that answer. When you put an incision, you have to leave a cuff of free gingiva. Okay. Or free alveolar mucosa. If you put an incision in the attached gingiva, you will not be able to suture it back when you finish your surgery. So whenever you put an incision, always make sure that you have a 4 to 5 mm cuff of free gingiva so that you can suture the intraoral wound again. Alright? So you put an incision from first molar of this side to the first molar of that side. You strip off all the muscles. Okay, whatever muscles are there in the maxilla, there is no direct muscle which is going to change the movement of maxilla. Mandible, the muscle influence the movement. But maxilla is not a mobile bone, it's a stable bone. So you can strip off the muscles. If you strip off everything, what is going to give the blood supply to the maxilla? How will the osteotomized maxilla survive? If you strip off all the muscles, भाई देखना तो पड़ेगा ना. Maxilla को काटने के लिए पहले maxilla को देखना पड़ेगा. How will you see the maxilla? You will see the maxilla when you strip off all the muscles, all the connective tissue, all the soft tissues. So what will be the blood supply to the maxilla after osteotomy? Very important MCQ. Blood supply to the osteotomized maxilla. 3 vessels. Very important MCQ asked in exam. What are the 3 blood vessels which provide blood supply to the osteotomized maxilla? Descending palatine artery, which is a branch of maxillary artery. Ascending palatine artery, which is a branch of facial artery. And ascending pharyngeal artery, which is an anterior branch, the anterior branch of the ascending pharyngeal artery, which is the direct branch of the ECA. रट्टा मार लो, इसमें कोई concepts nahi hai. It is just pure facts which you have to remember. Once you do a Lefort-1 osteotomy, पीछे से जो soft tissue envelope, the posterior soft tissue envelope, the pharyngeal soft tissue envelope of the pharynx, of the soft palate and pharynx, the palatine and the pharyngeal soft tissues are going to provide blood supply to your maxilla after osteotomy. And what are these blood vessels? The blood vessels means, cutoff means when you, there is an inferior alveolar artery for the mandible. Is there a similar single artery for the maxilla? No, right? There is no single artery which is supplying the maxilla. How is the maxilla getting its nutrition? How is the maxilla getting its blood supply? Through the soft tissue envelope, through the muscles, through the connective tissue. The soft tissue envelope of the maxilla is providing blood supply to the maxilla. When you are doing your Lefort-1 osteotomy, you are putting an incision and you are stripping off all the soft tissues, right? So your blood supply is cut off because your maxilla's soft tissues are removed. Now what is left is the posterior soft tissue envelope. The soft tissues which are attaching the maxilla from behind, palatal and pharyngeal tissues. And the palatal and pharyngeal blood supply, which is the descending palatine artery, ascending palatine artery and ascending pharyngeal artery. ये आपको किसी भी हालत में बचानी है. You have to save these vessels. You have to save these soft tissues. Otherwise, your maxilla will necrose. Instead of doing a beautification surgery, you would have done a necrosis of the maxilla. So you have to be really careful. Okay. So this is the blood supply of maxilla after osteotomy. Now, what are the kinds of cuts that you give? Okay. If this is the maxilla, I have to detach my maxilla anteriorly. I have to detach it from the lateral wall of the nose. There is a nasal septum also in between. I have to detach it from the nasal septum. And posteriorly, okay, if this is my maxilla, it's not my maxilla. If this is a maxilla, I'll take this one. All right. If this is a maxilla, I have to cut it from here. Okay. Detach it from the sinus. I have to do a cut here in the lateral nasal wall. Andar jaake bhi, I have to go inside and I have to cut on both sides, lateral nasal wall. Then I have to separate my maxilla from the nasal septum also. The nasal septum is made up of vomer inferiorly, basic anatomy if you remember. There is a septal cartilage anteriorly and posteriorly. There is perpendicular plate of ethmoid bone and vomer. So vomer, I have to do a vomerine disjunction. I have to separate my maxilla from vomer. And as the maxilla rotates, okay, let's see it from this side. As the maxilla rotates, I'll do a disarticulation resection of the mandible and show you. Okay. Like this. So you see when the maxilla is rotating here, this is the perpendicular plate of ethmoid bone, the perpendicular plate of sphenoid bone, which is connected to the maxilla through a sphenopalatine fissure. So you have to detach your maxilla with your from your pterygoid plates. Okay, you have to detach your maxilla from the pterygoid plates. So itne sare osteotomies, itne sare cuts you have to do, and there are specific chisels for every osteotomy. So for the front, there is a straightforward. You can do it with a burr, you can do it with a saw. You can do it with a piezoelectric insert, just like the ones we have used for mandible. But when you have to do your pterygoid osteotomy, the third one or the last one is the pterygoid osteotomy that you can see here. You have to separate the maxilla from the pterygoid plates. You will use a special instrument which is known as a pterygoid chisel, also known as the obvigescer pterygoid chisel. Alright. Another question which is asked on pterygoid chisel is what is the direction of the pterygoid chisel? So the direction of the pterygoid chisel has to be downward and forward. Okay, I will put my pterygoid chisel like this, downward and forward. If I don't do it downward and forward, I will enter into the skull, and I don't want to enter into the skull of the patient. So the direction of the pterygoid chisel has to be downward and forward, or anterior, downward and anteriorly. That should be the direction. Very important MCQ asked in exam. Another chisels that we use, I don't know why this picture is coming here. This is the lateral nasal chisel. It has never been asked in exam, but since pterygoid chisel is asked, this can also be asked. So this is a normal chisel with a safety tip. It is a paired instrument and it has a safety tip. Alright, how do you fix it? You fix it like this. The safety tip goes inside into the soft tissues, and the cutting part or the chiseled cutting part is outside. Plus these chisels have markings 1 mm, 2 mm, 3 mm, so that you know how much inside you are going. Alright. The another chisel is a septal chisel. It is used to separate the maxilla from the nasal septum. In that it's a single instrument, it's not a paired instrument because there is a single septum. There is a safety tip on both sides, and in between this part is the cutting edge. So you fix it like this on the maxilla. The safety tip takes care of the nasal soft tissues so that you don't injure the nasal soft tissues, the nasal lining. And this cutting part will cut the nasal septum and it will separate the maxilla from the rest of the midface. So these are the special chisels, the pterygoid chisel, the lateral nasal chisel, and the septal chisel. Once you have done your Lefort 1 osteotomy, it is the workhorse of maxillary orthognathic surgery. You can do your advancement, you can do your setback, you can do your impaction, you can do a down fracture. You can even split the maxilla in between and do a maxillary widening. But whenever you do a surgery with a gap, the stability will reduce. So when you do a maxillary down fracture, it's a less stable surgery. Whenever you do a maxillary widening, it is a less stable surgery. Yes, you can do it, but it is less stable. And whatever movement you are doing, advancement, setback, impaction, down fracture, whatever you're doing, you can fix the osteotomy in the end with 4 L plates. Okay? L plates are nothing but mini plates in an L shape. And the rule with mini plate is 2 screws on both sides of the fracture. So 2 screws up, 2 screws down, minimum 2 screws. You can use 3 also, but minimum you have to put 2 screws on both sides of the osteotomy. So this is also a repeat question, a repeat MCQ. How many L plates or how many mini plates do you need to fix the maxilla? 4. Why 4? We will read in trauma when we are doing Lefort 1 fractures. Alright. So this is how you fix the Lefort 1 osteotomy. No, it will not cause a veilopharyngeal insufficiency. Cleft will cause a veilopharyngeal insufficiency. This will never cause a veilopharyngeal insufficiency. Mostly it doesn't. Okay, one more question which is asked here is, when you do a BSSO, you do the final split with a Smith spreader. When you do a Lefort 1 osteotomy, what do you use to make that final split? For the final split, we never use an instrument. We always use the thumb pressure. So you do all the osteotomies. You do a anterior maxillary osteotomy, you do a lateral nasal, you do a septal osteotomy, you do a pterygoid disjunction. And to connect all of them, you use the thumb pressure. The surgeon will use the thumb pressure and fracture the maxilla down. That's how you do the final split. Thumb pressure, very important MCQ again. Thumb pressure to do the final split in Lefort 1 osteotomy. Alright. So this is all about Lefort 1. 2 complications which can happen here. Just like the witch's chin, there can be an alar widening. That is the first complication. So When we strip the mentalis muscle, there can be sagging of mentalis. Similarly, when we strip all the muscles from the anterior maxilla, the nasal ala, this is the alar cartilage, okay? This curved part of the nose is known as ala. And the base of the ala can flare, it can widen, okay? So the patient can say that, okay, you've done a good surgery, but my nose was very nice and slim. Now my nose is flared, I look like a frog. So in spite of doing a good surgery, where do we fix the 4 plates, Mohammed Jami? We will discuss it in trauma. Okay, I will not discuss it here. So when we do this surgery, we also have to take care of the soft tissues. So alar widening will happen whenever you do a stripping of muscles. How will you prevent it? You will prevent it with a special suture which is known as an alar cinch suture. CINCH is a LR cinch suture. So when you are doing your surgery, you can intraorally, you can catch hold of the ala from inside the mouth, from one side to the other side, and you can tie the both ala to the anterior nasal spine. We have an anterior nasal spine, a bony prominence in the ANS region here. If you can even palpate it if you put your finger here in the columella of the nose. You can palpate your anterior nasal spine. Create a small hole in the anterior nasal spine and fix the alar cartilage there intraorally with sutures. This special suture is known as alar cinch suture. So that is how you prevent the alar widening after Leafort 1 osteotomy. The second complication that you can happen after Leafort 1 osteotomy is upper lip thinning. Thinning of upper lip. Okay, the upper lip becomes thin, especially when you go up or when you impact. So the upper lip length can reduce. How will you prevent it? Again, just mug it up. You can do a VY plasty. You can do a VY plasty to prevent the upper lip thinning or to increase the length of the upper lip. What can you do to increase the length of upper lip? You can do a VY plasty. Alright? Convert the V-shaped incision, give a releasing incision so that the V is converted into a Y and the tension on these tissues is gone. So lip thinning can be prevented by VY plasty. Just remember it as it is. So this completes our Leafort 1 osteotomy, which is the workhorse of maxillary orthognathic surgeries. When you combine both Leafort 1 osteotomy with BSSO or IVRO, it's called a bi-jaw surgery. As simple as that, no special thing. Doing 2 surgeries together, you will create 2 splints. It's known as a bi-jaw surgery. Sometimes, instead of doing a maxillary widening, you combine orthognathic surgery with distraction osteogenesis. You put a distractor there. We will discuss this again when we are doing distraction. But instead of a single time separation, you put a distractor there and slowly you widen your maxilla. This is not an orthognathic surgery. It becomes a distraction procedure known as SARPE. What is SARPE? Surgically assisted rapid palatal expansion. So one palatal expansion you can do before the fusion of palatine sutures. Okay, that is the one that you do orthodontically using a hyrax. When the palatal sutures have fused, there is no scope of doing it orthodontically. Now you do a Leafort 1 osteotomy, you do a mid-palatal split and you put a distractor there and do a surgically assisted palatal expansion. This is not an orthognathic surgery alone. This is just an osteotomy followed by a distraction osteogenesis. Okay. Okay. Now we come to the stability of surgery. Most of the recent MCQs are based on this chart. Alright. Just remember, whenever there is a good overlap, the surgery is stable. Whenever there is no overlap, the surgery is less stable. So maxillary impaction, maxilla going into the midface, very stable surgery. Mandibular advancement, why is that asterisk? Because to certain limit, you can't do it an unlimited advancement. But still mandibular advancement, very stable surgery. Genioplasty, that is chin surgery in any direction, very stable surgery. So these are the three very stable surgeries. Opposite to that, surgeries with a gap like maxillary widening. Least stable surgery. This is the least stable surgery. Maxillary down fracture. You're creating a gap between the maxilla and the rest of the midface. The second least stable surgery. And mandibular setback. Why is mandibular setback least stable? Because of the pterygomasseteric sling. That sling will prevent the going back of the mandible. So these three surgeries are the least stable surgeries. And which is the worst? The worst is maxillary widening. Alright? So the least stable and most stable. Beach ka kabhi bhi koi nahi puchega aapse. They will ask you either the most stable or the least stable. So please remember these two kinds of surgeries, very stable and problematic. The last part of orthognathic surgery is the surgery first approach. Initially, in the beginning, I don't know why this pen is showing here, but in the beginning of superior positioning means taking the maxilla up, inferior positioning means taking the maxilla down. As simple as that. Initially, I told you that there is a conventional approach and a surgery first approach. Surgery first approach, you completely skip the pre-surgical orthodontics and you start with the surgery. Very limited indications. You just have to remember what are the indications of surgery first approach. Just the indications will be asked to you. First is well-aligned arches with very mild crowding. Slight crowding is there. You can manage it post-operatively also. Second is flat to very mild curve of spee. Okay, normally the curve of spee should be straight. If it is very mildly tilted, very mildly curved, that mild management, you can do it with surgery first approach. Otherwise, if it is a very severe curve of spee, you have to do the conventional. Third is when there is a normal to very mild proclination or retroclination of incisors. Okay, so the incisor relationship is also almost normal. Very mild correction is required. So all the mild things you can do by surgery first approach. When there is a minimal transverse discrepancy. Transverse discrepancy should not be much because that cannot be corrected with orthodontics alone. So minimal transverse discrepancy, you can go for a surgery first approach. When the skeletal discrepancy needs a decompensation for orthodontics. This is rare indication when the skeletal discrepancy is so severe that the orthodontist says that I can't move the teeth. First correct the jaw, then I will be able to move the teeth. Very rarely this happens, but in some cases this will happen. Alright. And the last indication which I don't follow is patient demand. Patient will say, nahi, mujhe ortho nahi chahiye, aap sirf surgery kar do. So that's the worst indication. These are the worst kind of cases and you should not really take these cases. But these two are the rare indications. Mostly very mild discrepancies. You can take up the case for a surgery first approach. Alright. So these are the indications. And the only limitation of orthognathic surgery is it depends on the size of the jaw. If it's a small jaw, you can do small movements. If it is a big jaw, you can do big movements. So for movements beyond the size of the jaw, you have to do distraction osteogenesis. Alright? So that's the only limitation. With that, we finish all the questions of orthognathic surgery. Thank you so much for being with me. Very quickly, we will revise the previous year questions and I will want you to answer these questions to me based on what you have understood. Alright? So, first question is, if impacted third molar is to be extracted in a patient for BSSO, when should the extraction be done? Come on, quickly tell me the answer of 1. So, answer it like this, 1A or 1B or 1C or 1D. Just write 1 and A, B, C, D. Tell me the answer to this question. So we will cover all the recent PYQs in this last segment of 5 minutes. Very good. So the answer for 1 is C. Very good. Anusha, Sara, Mausumi, Nitish, all of you. All right. Coming to question number 2. COGS analysis was given by. Come on, ध्यान से पढ़ो इसको and remember what I have answered. So right now, answer for question number 2. What is the answer to question 2? अब 2 पे आ जाओ, 1 हो गया finish. Very good. The answer to 2 is, thank you Prateek, Kajal, Vinitha. Answer is Burstone and Ligan. You are all correct. Answer is Burstone and Ligan. Question number 3. Surgery first approach can be used in all the following cases except. Come on. Answer to question number 3. Yes, Libra, Bidhi, Pooja, Bhavna, Vivekanand, Ven, Anshu, Aditi, you're all absolutely correct. Tilanjali, Aparajita, Rids, you're all correct. Question number 3. Very good. So the correct answer for question number 3 is a skeletal class 2 with TMD. Also tell me what is the best surgery for this. Okay, let's not go into it. Coming to question number 4. Analysis to be done in a case of facial asymmetry or facial symmetry. It's actually asymmetry. Before orthognathic surgery is, which analysis will you do for asymmetry? Very good, Anusha. You are absolutely correct. The answer will be D. Grumman's analysis, which is done on a PA cephalogram. Absolutely correct. Libra, Gauthami, Deepriya, Mohammed, Tilanjali, Bhavya, sab sahi ho. Which is chin deformity is a complication of which condition or procedure? Read this question very carefully, okay? Read this question very, very carefully and then answer. Question number 5. Here your deep thinking is required. Very good. The answer to this question is D and it is not A. Mandibular prognathism surgery means a surgery which is done to correct mandibular prognathism. The surgery for prognathism is BSSO. And BSSO is a surgery done in the ramus. It will not cause a witch's chin deformity. Horizontal positioning of mandible in relation to lower anteriors. Again, this is also a posterior surgery. You are changing the position of the full mandible. So it's either VRO or BSSO, which is a ramus surgery and not a chin surgery. Allergy will never cause a witch's chin. And genioplasty, autogenous block graft for chin augmentation. What is the meaning of augmentation? Augmentation means adding, addition of the chin. Increasing the chin's prominence is known as augmentation. So genioplasty is the last option and that is your answer. I'm very happy that most of you or rather all of you have answered it correctly. All right. Coming to the last question for this segment, question number 6. Which of these orthognathic surgeries needs a sagittal cut in the ramus? A sagittal cut. Question number 6. Which of these surgeries needs a sagittal cut in the ramus? Very good. The correct answer is sagittal split ramus osteotomy or SSRO. Very good. All of you are absolutely correct. Somebody is asking me to explain question number 3 again. So question number 3 is surgery first approach. Beta, seedhe indications. I have written 5 indications. Mild curve of SPE, mild crowding, mild proclination, all the mild things are indications for surgery first. Skeletal class 2 means there is a skeletal abnormality along with a joint problem. TMD is a big problem. So you can't correct it with the surgery first approach. You have to correct the occlusion and then do the surgery. Alright? So with that we finish the first big chapter in oral surgery, that is orthognathic surgery. This was one of the most difficult topics. I'm very happy that most of you have been patiently sitting and listening to the lecture. I know you are tired. Let's take a small half an hour break. Go eat something. Take a good half an hour break, or let's do it a 20 minutes break. Is 20 minutes okay with all of you? So I changed that question. I didn't ask you that question because the reason for class 2 is not given. Whether it's a class 2 because of maxillary excess or whether it's a class 2 with mandibular hypoplasia. If it is a class 2 because of maxillary excess, you will do a Lefort 1. If it is a class 2 with mandibular hypoplasia, you will do a BSSO. That's why I didn't ask that question, because the reason for skeletal class 2 is not given. Alright? Okay, so let's do a 20 minutes break, because then we won't be able to finish LA. Let's do this 20 minutes break. It's 8 o'clock now. It's 7:51 actually. Let's all meet at 8:10. Alright? Let's all meet at 8:10. Go take a break, eat something, and meanwhile, I'll give you a small quiz of just 5 minutes. Okay? In the Telegram group, there will be a quiz of all the things that we have discussed. Just 5 minutes, 10 questions, and take this quiz for a quick revision of whatever you have understood in this class. If there are doubts remaining, please don't worry. I will come back to your doubts and explain everything again at the right time. Alright? So let's take this break